gastroenterology. Currently, he was an assistant professor of medicine at Yale University Medical School in the division of gastroenterology. Now he is in a Princeton Medical Group and attending physician at the University Medical Center of Princeton. His topic today is GERD, the burning questions.
We'll just wait a few minutes for the slides, and you guys can all hear me. There should be a translation of the slides in the packet, so if you want to follow along, that's fine. It's just meant to be interactive. It should be between 10 and 15 minutes. We can do questions after the panel session, but if there are things that you think are relevant to the talk, just interrupt me. So I do gastroenterology. Recently joined Dr. Yi at Princeton Medical Group. My area of interest is actually the esophagus, and a lot of the training I've had has been with the esophagus, and so I've chosen to speak about a very common condition that really affects all of us, regardless of ethnicity, but is also a specific issue in the Korean American community. Many of you in the room, hopefully not too many, may suffer from GERD. And what is GERD? GERD is gastroesophageal reflux disease. People associate this most commonly with the symptom of heartburn. Really what this is simply is when things in the stomach, instead of moving downstream, go in the opposite direction and actually come up into the esophagus. This can cause a lot of symptoms. Clearly it's not a comfortable sensation of it for those of us who don't have this commonly. We've all experienced it at one point. Maybe some of us will have some issues after dinner tonight. But the reason I want to talk about this is because for those of you who do have frequent symptoms, this is not just a quality of life, every now and then burning sensation. It actually can lead to serious health consequences down the road, including esophageal cancer. So that's really kind of the main reason I'm speaking about it today. I did find a recent study that looked at Korean Americans specifically, and it turns out about 1 in 7 Korean Americans will experience GERD symptoms on a weekly basis. The two most common symptoms are heartburn and regurgitation. Again, regurgitation is actually the sensation of things actually coming up, whether it's food or liquid, up into the back of the throat. The risk factors for reflux are pretty simple. They're diet related, which I'll talk about. Obesity is certainly a risk factor, and then excessive alcohol intake all can predispose to reflux disease. So these are the burning questions that I think I get asked a lot in the office, and many of you have these questions, and I'm going to cover these in the course of the talk. Number one is GERD just heartburn? Are there other symptoms that also can be caused by reflux? Number two, what foods can cause GERD? Number three, when should you see a doctor? So I just mentioned that all of us every now and then are going to have these symptoms. When is it severe enough that you actually have to go in and see your gastroenterologist? Number four, we see a lot of ads now about acid-suppressing medications. A couple medications like Prilosec and Prevacid are actually over the counter now. So the question often comes up, well, how long can I take these? Are these medications safe? And then what's new with GERD? So GERD, for the most part, if you have heartburn or regurgitation, clearly that's a symptom of this condition. But there are also other things you want to watch out for. So if you have trouble swallowing, things you used to be able to eat now feel like it takes longer to go down. It feels like food is actually getting stuck. If you have a sore throat, often after you wake up in the morning, certainly there are other causes of sore throat, but GERD can be one of them. Chronic cough, and then chest pain. Now clearly when we think about chest pain, we're thinking about heart attack, angina, things of that sort. So your first stop certainly should be your primary doctor. But if you go through a cardiology workup and the cardiologist says your heart is completely fine, GERD is often to blame and it should be investigated further. People often think because the medicines we take for GERD all suppress acid in the stomach, people often think that GERD is related to the stomach making too much acid, when it turns out that's not the case. The real problem with reflux actually is with something called the lower esophageal sphincter. So this is a kind of a cartoon or a diagram of the esophagus and then the junction of the bottom of the esophagus into the stomach. At this junction is the sphincter. It's a valve. It's called the LES, or lower esophageal sphincter. And the real problem with people that have bad reflux is that the valve is weak. So whereas most of us have a certain pressure in that valve, which keeps things in the stomach, when that valve becomes weak, stomach acid, food, liquid can actually come back up into the esophagus. We don't have great medications yet. We're actually tightening up this valve, so most of the treatments we still use today are things that suppress the acid in the stomach so we don't get the burning sensation. So I mentioned diet being a cause of reflux. I think we all have foods or things that we drink that cause symptoms. These are the most common causes of reflux, and certainly it's basically everything we enjoy. So caffeinated beverages, coffee, tea, certainly, tomato sauce, chocolate, alcohol in excess, fatty foods, and then actually peppermint and things of that sort can actually also trigger reflux in some patients. So these are things that, again, if we're doing in moderation and we don't have symptoms, clearly is not a cause for concern. But if you are somebody who has bad reflux disease and you kind of indulge in one of these items, just stopping or decreasing how much you use these food substances can actually improve symptoms and may actually prevent the need for medications. Now, I actually did find one study specifically in the Korean community. It actually was not in the Korean American community, but it actually was done in Korea. And it turns out ramen noodles actually are the food that's most commonly associated with reflux symptoms. And the way they did this study in 162 patients is they actually gave them food diaries to fill out with reflux symptom questionnaires where they would actually rate after their meals how bad their symptoms were. And it turned out across the board, at least in this study, ramen noodles were the most, I guess, culpable food item. And then you can see some of the other things, spicy foods, sweets, which is interesting because that's not something commonly associated with reflux when you look at physiology. But in this particular study, patients often report symptoms, and then caffeine, whether it's in the form of coffee. Likely in this study, it was mostly consumption of tea. So what can you do? Well, a lot of the lifestyle changes that you can use to manage symptoms are quite, I think, intuitive and obvious. Number one, stop smoking. There's actually an association between patients who actually wear very tight-fitting clothing, causing excessive pressure on the top of the abdomen, causing reflux disease. We often encourage patients who have reflux at night not to eat or drink anything significant 2 to 3 hours before they go to bed. This allows food and liquid to actually pass from the stomach into the intestine and prevents reflux into the esophagus. If you do have reflux at night and this doesn't do the trick, you can actually elevate the head of your bed. And obviously, if you're obese, being a big risk factor for reflux, losing weight can help control symptoms. When should you see your doctor? Well, clearly, if you've always had reflux, say when you just go out to eat on, say, Friday or Saturday night, you have a large meal, you get heartburn, and that's kind of your pattern. If that pattern all of a sudden worsens, where now you're getting it several times per week, it seems more severe, it's not relieved by antacids, you certainly want to see your doctor. And then these other symptoms, I put a red flag here because in medicine we call these red flag symptoms. These are things that Dr. Yi unfortunately sees a lot in his practice in oncology. But these are signs that things are maybe getting worse and maybe progressing to some of the complications of reflux. So if you have food getting stuck, if you start to lose weight, if you notice bleeding, that can either be obviously vomiting blood, which is very dramatic, but more commonly just seeing a change in the color of your stools where it goes to a darker color, a black color. These are all red flag symptoms. These are concerning symptoms that certainly warrant a visit to the physician. And if you end up in a gastroenterologist's office, it's going to be hard for us to resist. But clearly, if you have any of these symptoms, we're going to move forward with what we call an upper endoscopy, which is a diagnostic test to look at the esophagus. This is kind of a cartoon of what that looks like. Patients are sedated, so you're comfortable, you're asleep. And we advance a tube with the camera on the end into the esophagus. And we kind of decide who gets an endoscopy based on symptoms. A lot of the red flag symptoms I've talked about, but clearly if you're somebody who has worsening symptoms, long-standing reflux, and over the age of 50, or a family history of esophageal cancer, we're going to have a lower threshold to move forward with endoscopy. The main reason we do endoscopy in patients with reflux disease who've had it for a long time is to look for something called Barrett's esophagus. Just by a show of hands, how many of you guys know what Barrett's esophagus is? So a few. So Barrett's esophagus we care about it. Essentially, it's a change in the type of cells in your esophagus. And we care about it because it's a precursor for a minority of patients for esophageal cancer. So what I tell patients, we've done a lot of education about colorectal cancer screening and getting colonoscopy once you're at age 50. Finding Barrett's esophagus is equivalent in some ways to finding polyps in the colon. It's not cancer itself, but if nothing is done about it, if it's not monitored, if it's not treated, it can progress to cancer over time. The risk of esophageal cancer with Barrett's esophagus is low, but we have to actually look at patients with Barrett's esophagus, number one, to find out who has Barrett's esophagus, and then to watch them every several years, every couple of years with endoscopies to make sure they're not developing changes on the way to So this is an important screening test, just like you would get a colonoscopy. With an upper endoscopy, we're looking at the bottom of the esophagus. What you see here is looking down in the esophagus at the junction between the esophagus and the stomach. The stomach here is this pinker tissue down below, and this whiter tissue, which I've labeled normal, is normal healthy esophagus. When you have Barrett's esophagus, you can see that this white area is now being invaded, so to speak, with this sort of salmon colored or pink tissue. And when this pink tissue is in the esophagus, we take biopsies and the pathologist will confirm the diagnosis of Barrett's esophagus. So it's very common in this country. About 3.5 million people have Barrett's esophagus, and most of these patients have long-standing reflux disease, which is why we look there. The only way to diagnose it is with endoscopy. Just like a polyp, if you have a polyp in your colon, you may have no symptoms if we do a screening test to find it. This is very similar. And most patients will not develop cancer, so this is not to be alarmist. It's not to say that if you have had a day of reflux in your life, you have Barrett's and then you're going to develop cancer. This is just to say that if you do have frequent reflux and you've had it for a long time, you should talk to your doctor about whether you need to be screened for this condition. Esophageal cancer, again, Dr. Yu probably knows, but many of us don't. Esophageal cancer in this country is the fastest growing cancer of any cancer, lung, breast, what have you. It's actually growing at the fastest rate over the last 25 years. And the thought is that a lot of that is driven by obesity in this country, driven by increasing incidences of reflux disease. In Asia, on the mainland and on the islands, the most common esophageal cancer is actually squamous cell cancer, which is not necessarily associated with reflux disease. In this country, it's adenocarcinoma, which is what Barrett's esophagus is a precursor of. The good news, if there is, about Barrett's esophagus is that you don't just go from Barrett's esophagus to developing esophageal cancer overnight. You actually go through changes called dysplasia, which is mimicked here in this cartoon, where the cells kind of become different, they become angrier. And this is why we do periodic endoscopy. We want to catch patients who are in this dysplasia realm, so we can offer treatment instead of waiting until they develop full-blown cancer. How do we treat reflux? We talked about lifestyle, we talked about diet changes. You also want to talk about medications. If you look at from weakest to strongest, there's antacids over the counter, Maalox and Mylanta. There's medications called histamine blockers, and Antac is the most common. And then there are the proton pump inhibitors, which are Prilosec, Prevacid. There's actually 8 of them on the market. All of these work by neutralizing or decreasing acid production in the stomach. The choice of whether or not you need a medicine or which medicine is appropriate for you, again, should be a discussion between you and your physician. Are PPIs safe? Again, PPIs being proton pump inhibitors. This is a very controversial topic. Many of you guys may have read, it's been in the New York Times and the Wall Street Journal. This is actually after these cholesterol-lowering medications, depending on when you look at it. These are the most widely used medications in this country. And so there's a lot of concern about patients who are taking it for 10, 15, 20 years or more as to whether or not these medications are safe. I've listed some of the theoretical complications and some complications that have been actually shown. I want to highlight one because it's probably the one that has the most data behind it, and that's thinning of the bone, something called osteopenia, which can lead to osteoporosis and hip fractures, especially in elderly patients. So this is a concern, and I don't think we know yet whether this is a definite relationship, but clearly, especially if you're a woman, if you're postmenopausal, if you have a history of osteoporosis yourself, and you are taking these medications like Prilosec, Prevacid, Nexium on a regular basis, is a conversation that should take place again between you and your doctor, just to make sure that you should be on these medications long term. The last few slides are talking about 2 particular advances within the realm of reflux in the esophagus that we have here at Princeton now for the last couple of months. One is something called wireless pH testing, which I'll talk about, and then the second is actually an endoscopic treatment for Barrett's. So I mentioned how if you have reflux chronically, you should get screened for Barrett's. But now we don't have to just sit there and watch it. We can actually intervene and get rid of these precancerous cells and prevent the development of esophageal cancer. So this is actually, you guys are all experts in endoscopy now. This is actually the view of the esophagus with this wireless sensor, which you can see here, which we attach just with a very small suction device into the esophagus. Now, if you had to get, this is used for patients who have bad reflux disease, potentially who may need surgery as a treatment. We always want to measure how much acid they're having coming back into their esophagus. And traditionally, the only way to do this was to place a catheter through the nose, attach it to a recorder, and then have the patient go about their business for 24 hours. Now, clearly, it's not comfortable for patients to walk around with this catheter. They have to go to work. Most patients don't want to go to work, especially if they interact with other people. I mean, if you're at home on the phone, it's okay. But the other problem with that is people didn't do what they normally did. They wouldn't eat what they did, what they would normally eat. They wouldn't exercise, and they would come back, we would look at all the evidence for 24 hours, and they would have very little reflux. And so they didn't really resume their normal lifestyle. So we didn't really get a good picture of what was happening in their day-to-day life. Now with the advent of this capsule, while we're doing the endoscopy, we can attach this little sensor, you wear a recorder for 48 hours, and people can go to work, they can exercise, they eat normally, and then they bring the recorder back in 2 days and we can upload the information. This capsule, which is very small, will fall off in about a week or so. Most people don't even see it come out in their stool. And it's a much better picture of what's happening with the esophagus. Now, not everybody with reflux needs this test, but if your physician, your gastroenterologist feels like your reflux is not getting better, the medications aren't working, maybe you need some other intervention, this wireless pH test is something that we do here now in Princeton. And then the last thing is talking about this radiofrequency ablation, this treatment for Barrett's esophagus. So we take your, people have had colonoscopies here, I presume, when your doctor finds a polyp, they don't leave it there and say, well, we'll see what happens in a few years. Well, they take it out. And we know that taking it out can help prevent cancer. So now we're starting to apply the same philosophy to the esophagus and saying if you do have Barrett's esophagus, especially if you have changes called dysplasia, we can actually go ahead and get rid of it, ablate it with this endoscopic technique. And it's a safe test. Again, you guys have all seen, you've seen a slide like this before where the white tissue is the esophagus, normal esophagus, and this pink tissue is the Barrett's esophagus. And hopefully we don't gross anybody out, but this is what the ablation looks like. This is a balloon catheter, which again, it's an outpatient procedure. It takes less than half an hour, similar to an endoscopy. We identify the Barrett's, which you see here. We pass this balloon into the esophagus. We place it where we need it to be. We blow it up, and we deliver this energy. And you can see we've actually kind of ablated the most superficial Barrett's cells of the esophagus. When we go back in 2 months and we look at this, you're going to have normal esophagus, normal cells replacing these Barrett's cells. And hopefully with that, preventing the development of complications of cancer. So the last slide is just a summary of these 5 questions we talked about earlier. Number 1, is GERD just heartburn? Well, it most commonly causes heartburn, but there are also other symptoms that you want to look for. Difficulty swallowing, chronic cough, sore throat, chest pain that can also be caused by reflux. What foods can cause GERD? Well, clearly spicy food, caffeine, again, depending on your particular diet, there may be things that we haven't discussed. When should you see a doctor? Again, if you're over 50, you've had heartburn for a long time, even if you don't have any of the red flag symptoms, you want to see your physician and probably your gastroenterologist for a screening endoscopy to look for Barrett's esophagus. Oftentimes, when this comes up, is when patients see their physician and they're referred at age 50 for a colonoscopy. If at that point you can tell your primary care physician, well, look, I've had reflux for a while. Do you think I also need to have an upper endoscopy? Very frequently, your physician can do both at the same time. You don't have to go under anesthesia multiple times. Acid-suppressing medications safe. If you're taking these medications, if you take these medications for a few weeks or a few months, I wouldn't worry about any side effects. But if you're somebody who's taking these for years and decades, clearly you want to think about some of the complications, especially in women. You want to think about thinning of the bones. And then lastly, we talked about 2 new advances within esophageal diseases, again, that we're able to provide here at Princeton. One is wireless pH testing, and then second is treatment, endoscopic treatment for Barrett's esophagus.